Hello and welcome to JAMA Health Forum Conversations. I am Dr. Sandro Galea. I serve as Dean of the School of Public Health at Washington University in St. Louis. I also serve as Editor-in-Chief of JAMA Health Forum. JAMA Health Forum is a peer-reviewed, open-access online journal focusing on health policy, health systems, and population health, one of 12 specialty journals in the JAMA network. Today we are talking about the role of market forces in U.S. healthcare. The debate between government and market forces is as old as American health policy itself. At a moment when public sector expansion faces fiscal and political limits, many are reconsidering how market mechanisms, if carefully designed and regulated, might complement public strategies to improve access, affordability, and innovation. To discuss this, I am joined today by Dr. Lanhee Chen, the David and Diane Steffi Fellow in American Public Policy Studies at the Hoover Institution and Director of Domestic Policy Studies in the Public Policy Program at Stanford University. Dr. Chen has served in senior government roles, including as policy director for the Romney-Ryan 2012 campaign, and has written widely on health reform, state innovation, and the balance between competition and regulation. His recent JAMA Health Forum pieces have addressed early lessons from state-based public option plans and the limits of price containment efforts in California. I'm really delighted to be speaking with him today. Welcome, Lanhee.
Thank you, Dr. Galea. It's great to be with you.
So let me start broadly. You've written recently, and a fair bit of it in JAMA Health Forum, about government and markets, that they do not need to be at odds in health policy. Tell us a little bit about your vision for a pragmatic balance between regulatory oversight and market innovation.
Well, I think balance is the key word. The challenge we have is that our healthcare system is quite complicated, as presidents observed recently. And as a result, there is this need for us to consider how government plays a role, both state and federal, in balancing against what are very strong private sector market mechanisms in our healthcare system. And so the ideal system is one where there is this balance of a need to set rules and guardrails and boundaries, and also a need to understand that innovation happens in the private sector. Innovation happens in private markets. And when you have a system where the regulatory edifice is too significant or too strong, that creates an imbalance. And on the other hand, when you have a system where there are not sufficient understandings or guardrails around the market, you have a system also that doesn't function particularly well when you think about the distribution of health benefits. And so an ideal system is one that promotes innovation, that allows market participants to understand the rules, for those rules to have a certain amount of endurance, in other words, for them not to be changing all the time, and for oversight to be conducted, again, in a predictable and reasonable fashion. Now, that's much easier said than done, but overall, that should be the general philosophy that drives the balance between government involvement and market forces in our healthcare system.
I agree in many ways. So, in your recent commentaries in JAMA Health Forum, you've written about the challenges facing state-based public options and the trade-offs they face between cost containment and provider participation. Tell us a little bit more about that. Tell us about what you think these experiences teach us about the limits of top-down reform and what better alternatives might be.
When the Affordable Care Act was debated back in 2009 and 2010, there was discussion about adding a public option at the federal level. That policy was ultimately dispensed with, both because of political as well as more policy-based objections. And in the years that have passed since then, there's been increased interest among states in creating these public option proposals that would effectively compete with private plans in state marketplaces. Now, in many states, marketplaces have not functioned the way that we would like. The amount of competition in plans has not been great. Prices have been generally prices for premiums. Premiums have been higher than we would like to see. And so that has really driven, I think, some of this impulse in states like Colorado and Washington and Nevada to create these state-based public option plans. The challenge is that in the research that we have conducted at the Hoover Institution that I've been a part of, we've seen a couple of things. First of all, these plans oftentimes do not produce the long-run cost savings that we would like because taxpayers end up having to subsidize some of the cost of these plans. And so the overall cost ends up being higher than we might expect. But the bigger issue is something that you've identified around provider availability. And what we find is that in a couple of states, provider participation in networks that are part of these public option plans has been much more limited than one would like. As a result, access to care has been limited as well, or will be limited. So the limits of these sorts of plans, I mean, they sound very attractive at first blush. The reality, though, in the longer run is that you do have access questions and concerns as well as cost access and concerns. And these are things that have to be debated and discussed as we go forward.
So I've long thought that markets can work in healthcare if there are particular guardrails. And I recently wrote an editorial for JAMA Health Forum talking about competition, transparency, outcome-based payment, equity as guardrails. So if you were to think about guardrails, and I think you and I agree that there need to be guardrails, which ones do you think are most important? And conversely, which ones are the least well-developed in the current system?
Well, unfortunately, I would argue that the ones that are most important may be the least well-developed.
Yeah, I thought you might say that actually. Yeah.
Well, and I think transparency is a good one. That as I talk to people who are involved in healthcare policy, regardless of what their political leanings might be, regardless of what their ideological point of view might be, there is a broad set of, I think, terms around which people would agree. And one is that consumers of healthcare need to have a better handle on what they're getting. And there needs to be a little bit more government activity in this regard. So the notion that we can have a completely free system where transparency is just going to pop up, I think, is unrealistic. I think that government needs to play some role in saying there have to be, for example, there has to be more transparency around pricing of services, of plans, but around more than just pricing, because that's not the only dimension that we care about. We also care about quality as well. And quality has been a kind of vexing thing in terms of measurement as well as in terms of expression. Just for a moment, if you allow me to make a comparison, if you think about the system of healthcare they have in Singapore as an example, and Singapore is a much smaller place and they have a lot of cultural differences from America, they have a system where there is broad transparency around both price and quality. And there is some anecdotal evidence to suggest that that has driven down cost of healthcare as well as the overall consumption of healthcare. I mean, they spend about 3% of their GDP on healthcare. We spend almost 20. And so I do think that there is this kind of challenge that we have around how to create a system where that kind of transparency is available, because there will be salutary benefits to that. So that would be, I think, one that we should start with that I think would garner support regardless of one's political persuasion.
So building on transparency, I mean, many commentators and policymakers have thought of price transparency coupled with things like consumer financial tools, like health savings accounts, as a way to make markets function more effectively.
Sure.
Talk us through how much consumer choice realistically can create better value in healthcare, and what are the limits of consumer choice?
Yeah, I mean, it's a great point, because the mechanisms like flexible savings accounts and health savings accounts, which are more recent, hold tremendous potential. They're not going to be for everybody, and not everybody is going to be positioned to use those accounts well. But the notion that people can save and invest for their own health care has to be coupled with market signals that allow them to make educated decisions. Otherwise, it's like trying to go and buy any consumer good without any sense of what that good does, how much it costs, what the benefit will be. If you think about any other part of our economy, we don't have that. No one would ask you to go buy a television or a computer without doing some research on how much that thing costs and the benefits it produces. Well, healthcare in some ways shouldn't be any different. The challenge created by broad adoption of these approaches is that without that transparency of cost and quality, it's going to be quite challenging, I think, to produce the kinds of outcomes we want from these consumer-driven systems. I believe we need to make those consumer-driven plans more widely available. I've been in favor, for example, of loosening some of the rules around health savings account adoption. I think that's important, but it's not sufficient in and of itself. In other words, those who seek policies that only say, hey, we should expand consumerism by making these plans more broadly available without also addressing the other side of the coin, which is how are consumers and patients receiving the information they need, I think are missing the point a little bit and are not going to see results that, frankly, are salutary in the long run.
Yeah. Let's shift a little bit. Let's talk a little bit about consolidation. So you've argued that consolidation among hospitals and insurers weakens true market function. How would you approach the problem of market concentration differently from current antitrust and payment reforms?
Well, this one is a challenge because, first of all, there are differing definitions about what is appropriate consolidation and what is not. Different regulatory authorities, different regulatory bodies define market concentration in different ways. There are also different measurements of what the impact of that consolidation is. So if you look at what's happened in some markets in Northern California, which is where I live, for example, you will know that market consolidation has had a tremendously negative impact on pricing. In other words, it's made healthcare, in my view, much less affordable, and some of that market consolidation has been addressed by market regulators. And in other places, there might be a more open debate. But I think fundamentally what we do need, this is an example, we talked earlier about having rules of the road. This is one area where I do think having a shared understanding of, first of all, what constitutes inappropriate consolidation, but second of all, what the remedy is for that. I think that's important as well, because the notion that you just sort of go in and break up the monopoly, so to speak, that doesn't necessarily answer the question, because healthcare is a little bit more complex than, let's say, aviation, where when you go in and deregulate the airline industry, you might have one set of results. Healthcare is going to be very different and requires, I think, a more deliberate approach than just saying, let's go bust up a big player and figure out, we'll pick up the pieces later. I think you need a more deliberate approach that says, okay, if we are going to go in with a certain set of enforcement activities, what does the road ahead look like in terms of having a competitive landscape that then results? Because ultimately, we don't want to create competition for the sake of creating competition. We want to create competition ideally to drive down cost and drive up quality. And so that should be the lens through which regulators examine these questions and ultimately achieve the answers they want.
So you and I are talking in 2026. So it's a time when we are really coming off a period where we've seen very visible signs of public frustration with the healthcare system and around issues like drug pricing, insurance design, and some of these consequences have obviously been lethal. So how do you think about reconciling the need for competition with protection for patients who lack the resources, and perhaps even more beyond protecting patients, creating a system that feels fair and reasonable to people?
Well, this is another challenge when we talk about healthcare. Is one of those things that everyone is going to need at some point. It is not your typical good or service, and that's why it's a little bit different. That's why our economy has treated it a little bit different. I do think there is this challenge around how to make sure that there is access, broadly speaking. And that's why, of course, we have this structure that combines what is a very popular private system with also a very popular public system, particularly around Medicare. Now, Medicaid, I think, is going to be the biggest point of policy contention and potentially innovation over the next several decades in healthcare. I really think that Medicaid was a program that for many years went understudied, underdeveloped, and underused. And now what we're at is we're at a place where it has become the principal form of coverage for tens of millions of Americans across multiple parts of America. And the program itself has undergone some changes, and occasionally states will innovate. But broadly speaking, the program structure has been in place for at least a few decades. And this is one area where I think we are going to have to see, first of all, more private sector innovation, both around coverage as well as around how to make programs more accessible. And I'll give you one concrete example, which is telehealth. This is an area that has been increasingly used in the Medicare program, but in the Medicaid program, we're just kind of getting to the point now where we're seeing, are there some interventions via telehealth that could be helpful? So that's just one example, but more broadly, we are going to have to see program innovation in Medicaid to address both the issue of A, more and more people getting covered by the program and needing to use it, but B, the lack of access that creates, because we see physician flight in many places like California from the Medicaid program, and we need to figure out how to keep the program accessible, but also finally affordable. More and more states and governors who I speak to and teams at the state level are concerned about the fiscal health of Medicaid, and these are going to be challenges that we have to address in the coming years to ensure continued access, but also quality for participants in the program.
Yeah, sort of relatedly, you've written quite a bit about federalism, about the centrality of allowing states to innovate within broader federal frameworks. Talk us through what lessons you think are most salient today from state-level experiments that should inform where we move nationally.
Well, the first might be somewhat obvious, which is that different states have different needs and therefore will innovate in different ways. We have seen this in the Medicaid program. I mentioned states have gotten waivers to experiment with various things. For example, more states with greater rural populations have had to figure out how to cover those populations cost effectively. So there are programs that work for some states that won't work for others. I think that's the first lesson. The second lesson is really around scalability. And I think this is something that we're just starting to figure out now, which is to what degree are successful programs in one state scalable to others that might have similar concerns and issues. There is a provision in the Affordable Care Act contained in Section 1332. It's called a state innovation waiver provision. And that is something that allows states to innovate around their own healthcare programs in conjunction with the requirements as well as the benefits set out in federal law. And a number of states have tried to create programs that respond to this. And I think that's the kind of innovation where we're going to see more and more opportunity develop over the coming years if we allow states to engage in the innovation we know they're capable of.
Well, let me end with a looking forward question because I feel that that's appropriate. So, as we think about the next phase of U.S. health reform, what would be a credible market-oriented agenda for the next decade? And perhaps one, if we're to be optimistic, around which both parties could engage seriously?
Well, here I really would focus on the question of how we expand the supply of healthcare, because I do think that some of the questions around coverage and access on the demand side, as it were, are quite politically fraught right now. The supply side is really where I think we have some opportunity. And there we have, for example, questions around the efficacy of existing laws that constrain the supply of healthcare facilities, like the ACA prohibition on physician-owned hospitals, or state-based laws called COPA or Certificate of Need laws that basically put extra regulatory review in place that has hampered the development of new healthcare facilities, or maybe more controversially in some cases, removing restrictions that allow other clinicians who are not physicians to provide healthcare up to the top of their licenses. I'm thinking, for example, of restrictions on nurse practitioners in many states. These are the sorts of policies that in some cases will be pursued at the state level, in some cases pursued at the federal level, that have the potential to garner broad support across ideological points of view, but that also I think could do a great deal to bring down the cost of healthcare and make it more affordable for more Americans, to look at the constraints that really are restricting supply, and as a result in the supply and demand calculus, creating a higher cost basis for healthcare than we need to see, particularly in some parts of the country where there may be less competitive healthcare markets.
Thank you, Dr. Chen. Lanhee.
Thank you very much.
I am Sandro Galea. I'm speaking to Dr. Lanhee Chen of Stanford University and the Hoover Institution. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com, jamahealthforum.com, or look for JAMA Network wherever you get your podcasts. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.